All right. Welcome everybody to Starting Ettinger again. And we are celebrating Starting Ettinger again with special guests this morning. So first special guest is Josh Bool, who everybody knows already. Josh has been medicine resident for too long now and has been involved in rounds since the very beginning. And because we're starting Ettinger again, Josh is going to start to sort of have a little bit more involvement in running the rounds and introducing a little bit more sort of high level information than we're getting just from Ettinger. So Josh is going to present the neurologic manifestations of systemic disease this morning. And second special guest this morning is Alex Moore. Alex is the first time here. So Alex is a dermatology registrar and has just moved from Perth back to Sydney and is doing some dermatology work with the Vets North in terms of sort of telemedicine, consultations, case advice, and reading sort of histo reports and stuff and case input. So keep an eye out for her. We'll sort of get more information about what the options are and how you can utilize her, and hopefully she'll come out and meet you guys soon. Paul McCarthy is supposed to be here. I'm just putting that on the record because if I have to present ophthalmic presentations of systemic disease, we're all in trouble. So do you reckon we start with derm just because that was the first chapter? Is that all right, Alex?
Sure.
Yeah, excellent. Do you want to just kick off and I'll try and keep up with the photos?
Okay.
Awesome. Do you want, so typically what we do in rounds is try and keep it really casual, interactive. Is there any dermatologic presentations of systemic disease that people really want to cover? Because the chances of us getting through everything in detail are pretty slim.
What about like drug reactions?
Cool.
Yeah. I think just what's most common, because I just haven't seen it that often, so most common, I guess.
Yeah, I mean the various hormonal alopecias, and some of them we're familiar with, but like some of the sex hormone ones are less common. That and also autoimmune, immune-mediated diseases.
Yeah, excellent. So we've got all of those on our list, I think, between us. Alex, do you have a preference where you start?
Maybe let's start at the more sort of common endocrinopathies, and then we can get into the more interesting, little bit rarer kind of presentations.
Cool. Any in particular you want pictures first?
Let's go with Cushing's. I think there was a few. I mean, we all know what Cushing's looks like, but just to get my face off the screen and put a dog up there instead.
Excellent. So let's start with whoa, that's a poster child.
Lovely. So I guess, yeah, feel free to ask any more specific questions. Just going to focus on the skin for now. We all know most of the rest about Cushing's in terms of diagnosis and, presentation. As Anna said, this is pretty much a poster child for Cushing's. So I think we do see in referral derm quite a few cases of hyper A, and there are some that sort of fly under the radar and have sort of been managed for atopy or something similar, most of their lives, or those more iatrogenic cases that have been on prednisolone and sometimes scarily high doses, or sometimes not even high doses, but just long-term steroids. And we do know that obviously there's other antipyretics and anti-inflammatories available to us now. So I think that iatrogenic Cushing's is something, unfortunately, that is quite common. And so I guess with the Cushing's disease from a derm perspective, the main things I just wanted to really talk about, just diving a little bit deeper, is we know cortisol in moderation is good for us, but in excessive amounts, it's not good for anyone. And it's certainly not good with the skin. So what it does is it makes the skin really susceptible to secondary infection. And it does that at a deeper level by affecting collagen synthesis. It reduces the skin turnover. It affects the cell cycle. It reduces our skin elasticity, so specifically reducing elastin production. And of course, that's why we see that dermal atrophy. And I think, Anna, somewhere in there's a good photo of that classic sort of paper thin skin that we see commonly on the ventrum and the inguinal area. And the lack of sort of, there we go. Yep. So the skin tenting, and it just fails to fall back in. It's lost its elasticity and its sort of structure. And then I think the other thing that's really common, the skin microbiome is becoming a bit of a hot topic at the moment. And skin like this is not healthy. We can all appreciate that. And so the balance of microbes on the skin, good and bad, is disrupted. And so that's sort of another reason as to why we see the secondary infection, because not all these dogs are paretic, but the ones that are, of course, I think that's when we sort of think allergy, the dog scratching. But once you treat the secondary infection, you can clearly see that this is a Cushingoid dog. So another sort of, I guess, red flag for Cushing's is the comedones. And does anyone know if we see comedones, what another potential diagnosis, just talking about the skin, could be?
Thyroid?
Thyroid, yep. That's a good one. One more I'm sort of thinking of. It's not endocrine. So Demodex.
Yeah.
Yeah, good. So I once had a little pug, and he'd been referred for environmental allergies. He was itchy, secondary infection, flipped him over, looked at his inguinal region and full of comedones. Give it a good squeeze and did my deep skin scrape, Demodex everywhere. Couple of courses of isoxazolines, and that atopic dog was no longer atopic. So definitely looking out for those comedones and putting the dog on an isoxazoline. I guess what I'm trying to say is, like, treat infection, make sure that there's sufficient Demodex control, and just as a dermatologist, we kind of start with those really basic things, which sounds obvious, but before you go doing your stim test and all that kind of stuff, before you sort of dive in, I think that's probably a really good point for new grads, because a dog like this really does look Cushingoid. And the first thing you want to do is, you stim and you low-dose dex, but take a step back, get the dog comfortable, especially when it looks like this. Can you imagine? Treat the infection, culture if needed, because particularly these dogs have had long courses of cephalexin and clav, and often it's MRSP or some disgusting resistant bug. And so superficial culture is always a good thing with these guys too. And then I guess the next pick, Anna, if you've got something there, would be calcinosis cutis, because that's something we probably see a lot of as well.
The CC?
Yeah.
Oh,
Well, that was a really clearly awful case
ow.
of calcinosis. So obviously we see this with probably more iatrogenic prolonged steroid use. And I'm not completely sure, maybe someone else knows, but brachycephalics seem to be predisposed to this. I don't know if there's any studies, but certainly in my experience, Frenchies, pugs, all those guys, Bostons, mainly Frenchies, to be fair. And it's always along the dorsum and the dorsal neck where they've got those deep kind of neck folds. So I'm not sure if anyone else sort of agrees with
Agree. Yeah.
that sort of case and breed predisposition. But this is something we get sent all the time. And my mentor used to say to me, you're never going to get on top of calcinosis cutis if you do not get that dog off steroids. So the medicine guys might not like to hear that, but from a derm perspective, at least, we do always try to encourage using other drugs where possible. But if your focus is treating the calcinosis, then off steroids, topical, oral, even ophthalmic eye drops is recommended to stop.
With the
Has everybody
Frenchies,
felt this?
do they have infection like concurrent? I mean, obviously they'd have
Yes.
some concurrent infection, like with their like predisposition to E. coli issues in the colon. Like, do you think is it a more complicated calcinosis that has more bacterial elements than other breeds?
Maybe. I'm not completely sure, to be honest, but I have a pug, full disclosure, so I do love my brackies, but the Frenchies in particular, they're a broken breed, aren't they? So I think we probably fully don't understand all that's going on, especially with the whole gut skin axis and how it's all connected. That's a really good point. Maybe, I'm not sure, but this calcinosis, like this dog in particular, you can see on the screen, that was the most horrible, deep infection. We took biopsies for deep tissue culture as well as histopath, of course. And this dog needed antibiotics for 12 weeks plus or so. And even then, I think, you know, when it's this sort of end stage, topicals help, but it never fully resolves. And so the other points I kind of wanted to make about calcinosis cutis, obviously it's calcium deposition deep in the dermis, often on the dorsum, especially the dorsal neck. Even though I guess there's not, in my experience, correct me if I'm wrong, anyone, too many other things this could be, especially with the right sort of presentation and history. We do recommend biopsying this. And particularly for me, I guess what comes to mind is I was up in remote WA and I had a dog who'd been on steroids for years for skin and was referred for suspected calcinosis cutis, but I was sort of a young resident at the time and I just thought, I don't think this is quite right. So I took biopsies and it ended up being osseous metaplasia, which is of course end stage calcinosis cutis, where the calcium actually turns into bone. And so this dog had bone in its dermis. Like, that's crazy. And so obviously nothing is going to work for that. And unfortunately it was so diffuse all the way down this big sort of staffy mastiff cross, like you couldn't even surgically resect it. And so I guess biopsy is always indicated. Does anyone have any thoughts on treatment options or anything like that?
Treat infection.
Yes. I love it. Yes. So definitely treat infection. Probably we also clip. So the first thing I would do is just clip it all up with the owner's permission. And then you can really see how widespread, how diffuse it is. You can palpate it easier. Topicals can be applied better. Take your biopsies and then start treatment. So certainly because it's such a long course of antimicrobials, you do want to get sort of treatment for the calcinosis going rather than, you know, waiting to treat the infection, like I just mentioned for a Cushing's dog. So you can use these meds concurrently. So clip it up. We use aqueous chlorhex, 3 to 4%, nothing less, or it won't kill the staph. Get the owner to dab that on. Spray it on works really well, once to twice a day, and then something like flamazine. I like a barrier cream, like pseudo cream, gives the owner something to do, and, you know, it's a little bit antiseptic, doesn't cause any harm, and I think it can be soothing. And then in terms of treatments, in my experience, there's 3. So one is DMSO, which full disclosure, I have never actually used, but I know that's probably one of the more common, but also old school treatments. The US guys use it a lot. When I went to California and did some work over there, that's probably their go-to. You do have to tell owners to wear gloves, of course, wash your hands after. So DMSO, it's a topical gel. You can get it compounded, and it's anti-inflammatory. At a deeper level, it basically captures free radicals. It's anti-ischemic, and you apply it once a day to start with, or every other day if the dog's particularly sensitive. Looking at this dog, I would probably start with every other day, because there are reports in people of a burning sensation when you apply it. So, you know, less is more to begin with until the dog gets used to it. Probably my personal favorite treatment is minocycline. So an oral tetracycline, of course. I use this at 5 mg per kg twice a day. And how it works is, apart from all the usual tetracycline properties, is it inhibits MMPs, so our matrix metalloproteases, and then it reduces calcium deposition. And then lastly, there's a few case reports, and I have tried this of using Mylanta, so the human oral antacid, so aluminium hydroxide. And how this works is that it binds phosphate, which is then excreted as aluminium carbonate, and then the calcium absorption is increased due to that decrease in phosphate levels. So it's taking it out of the skin and getting rid of it in the body, which is what we want. Mylanta has worked, but personally, you have to use the double strength tablets from the chemist, and I've just found it can cause a bit of nausea, GI irritation, so mainly vomiting, and it does have to be given 2 hours before or after any other medication. I think that might be the same for people, and so it's a little bit tricky to have owners do that. Yeah, so any other thoughts or questions on calcinosis or Cushing's or anything? Alrighty.
Should we switch from endocrinopathies to an inflammatory one?
Sure. So I know, Anna, I sent you lots of cutaneous lupus photos, and then I sort of thought, well, it's not really fitting in with the systemic manifestation, but if anyone is keen to talk about particularly like discoid lupus, I think that's probably something relevant and common for GP practice. We get so many DLE referrals, but happy to be guided by everyone else.
Is everyone happy with that? I've actually got a dog at the moment that I'm suspicious it's lupus. So great for me.
Okay. Alrighty. So I guess the whole sort of lupoid disease category, obviously cutaneous only. We do see SLE, but that's a whole nother lecture, I think, and I'm probably not the best person to focus on that. So cutaneous lupus only. There is an excellent review paper by Thierry, so the derm god, for anyone who doesn't know him, published in 2018. And that is just a really nice summary of all the different variants. Let's just focus on DLE and sort of facial cutaneous lupus for today, but there are other weird ones like vesicular and mucocutaneous, etc. We do see them, but I think this is probably the most common one. And so again, just brief overview, I guess, going back to the Cushing's, oftentimes these dogs have infection. So culture is never a bad idea. I believe in Sweden, actually, interesting, I learned this the other day, they don't prescribe any oral antibiotics without performing a culture. And so their MRSP rate is significantly lower than the rest of the world, which I thought was really good. And so for these guys, I guess, by the time they see us, they have had a few courses of antibiotics. So treat infection. Maybe, Anna, if you could flick to the one that just focus, there's quite a few, but just focuses on the nose to start.
Oh, the one that you sent through separately?
I think so. Oh, no. There's ones where it just has like depigmentation of the nasal plane. Yeah, maybe those ones.
Oh,
yeah. Perfect. So this is kind of the classic presentation, and it is exacerbated by UV light. So we do seem to see these sorts of DLE cases more so in spring and summer, and then it kind of regresses. Owners just keep an eye on it during winter, and then it comes back again. And so that kind of fits in with the whole I guess, immune-mediated or autoimmune diseases. There is this UV influence. So always think that if there's kind of that chronic waxing and waning, never really going away kind of history. So DLE, the early lesions, this one's probably a little bit more chronic. The early lesions you see just affecting the nasal planum is actually not a color change. It's the loss of the cobblestone architecture. So if you look really closely at a dog's nose, you can see it's a bit corrugated. Yeah, there might be another one. Yeah. And so the first thing you'll see is that loss of architecture. So often owners and even we sometimes, don't really pick that up. And the first thing that the owner will notice is that the nose, where instead of being black and pigmented, it changes to like a slate gray or a light gray color. And so that should be a red flag in your mind saying, okay, maybe this is cutaneous lupus or DLE. So on that note, DLE, discoid lupus erythematosus, cutaneous lupus. Sorry about my dogs. or nasal lupoid dermatoses. There's lots of different names for this condition, but they all mean the same thing. So then this is probably a little bit more of a chronic disease process in whereby you can see the erythema, there's scale, there's crusting. Looking at this nose, I guess, what do we know what other maybe differentials we'd be thinking about apart from like solar or actinic? The main one really in a younger dog, middle-aged.
Insect bite hypersensitivity?
Maybe if it were a cat, I would say yes. Mosquito bite hypersensitivity. I was more thinking pemphigus foliaceus. That's more of a crusting disease. But there are certainly some cases of DLE and pemphigus where visually you just can't distinguish between the two. So again, biopsying. And when you do biopsy, actually on that note, you want to aim for those early lesions where they're grey. You don't want to go for, say, smack bang dorsal center, yep, there, because there's no epidermis, and so that's where your disease process is, and so you're going to miss, you know, the diagnosis. So I think photos on that note is also really good to send to the dermatohistopathologist, as well as your DDXs, of course. And then just going back to differentials, looking at that nose, particularly if it was an older dog. The other thing I'd be thinking about would be epitheliotropic lymphoma or cutaneous lymphoma, and sometimes it's just the nose that's affected. So again, biopsy.
Alex, I read that this DLE can actually affect the nasal turbinates as well and present with epistaxis. Have you ever seen that?
I've not seen it, but I have heard about it. And I know that there's some thought in using like LED light, like laser light therapy now.
In the nose?
Super new. I
Wow.
don't know much about it, to be honest.
Cool.
But yeah, I've never seen a case myself.
Awesome.
Yeah.
Now we are going to have to hand over to our ophthalmologist in about 2 minutes, if that's all right. Is there one more topic that you want to just run through real quick?
Sure. What other photos have we got there?
Could I just ask one question about the lupus? I'm just curious. Do you think clinically, based on the lesions there, you can tell the difference between that and like UVD, for example? Just because I only ever see UVD when it's got uveitis as well. So but sometimes I know that the dermatological signs can precede the ocular inflammation, and I'm just wondering if there's, because I don't really know much about skin other than when it gets affected by UVD. So I'm just curious if there's a way you can differentiate.
Can you tell us what UVD is?
Oh yeah, uveo-dermatological syndrome.
Right.
You might have heard of it as VKH as well, or Voigt. I can't say the name, but that's basically the human equivalent. And the difference between humans and dogs is that in humans it also attacks the meninges because there are pigmented cells in the meninges as well, whereas in dogs we don't see that. So in dogs it's more correctly uveo-dermatologic because that's the only areas that we theoretically should see disease.
Interesting.
I guess I would say just from, you know, common things happen commonly. I personally in the case, but DLE, I couldn't tell you how many DLE cases I've seen.
Okay.
But I think I would think DLE would be less severe in terms of its presentation, especially sort of in those early stages, and probably less erythemic, I would imagine. And like the ulceration you see with DLE is really quite not end stage, but that's a chronic case if you're seeing sort of erosion and ulceration, especially if the dog's got a history of where it lives outside and, you know, UV avoidance is just not possible. They're the kinds of ones you see. And most dogs these days, especially in Sydney, are in apartments, you know, in the aircon. I know my dog is all day long, like living up. So yeah, but again, I haven't seen a case, so I'm not completely sure.
Okay.
I found this picture. The last one.
One more.
Yeah.
So this is EM, erythema multiforme. This was a really cool case I saw in America, actually. So EM, just tying back into the drug reaction, that's the most common thought as to what triggers this, but oftentimes you don't actually find a definitive cause. like most things in vet medicine. But in terms of what drugs you want to get a full history, so I believe TMS, penicillins, and cephalosporins are the most commonly EM-inducing drugs. And so other things you always want to check, is the owner using anything, especially topically, that the owner might be using and then picking up the dog. Any history of vitamins, new flea products, supplements, like change in diet, absolutely anything. And again, oftentimes you don't actually find the cause. So EM, it can be quite mild, to be honest. It can be quite focal. Sometimes it can just affect the muzzle, but these photos are more of your classic kind of presentation where the dog is really quite systemically unwell. They're anorexic, they've lost weight, they're pyrexic, they're just really dull, depressed. And I think these lesions are quite painful. Like you can see what's going on that pinnae there. So the classic lesions are sort of your annular, serpiginous, crusted, plaque-like lesions, I guess. And again, biopsy will give you the definitive diagnoses. And then, there was something interesting I read in that sometimes people question, is this sort of an immunologic food allergy reaction as well? So again, maybe just seeing if there's any history of diet change. There's a lot of trouble in terms of the classification, so it's really still unknown in dogs, but they talk about major and minor. This would be major because it's affecting more than one sort of area of the skin, including more than one mucocutaneous junction. And then interestingly, in people, the trigger is often herpes virus. So in dogs, some reports say to check for a history of herpes and parvo, but I don't know if we've ever done that, to be honest. And then treatments is immunosuppressives. The really mild cases can be self-limiting, but I think that's probably quite a classic photo of EM. So if you see that, that should come to mind.
Do they start as like raised, almost pustules and then rupture? Is that what is making them look like that?
More plaques. Pustules would make me think of PF, pemphigus.
Oh, okay. Yeah.
Sort of more alopecic, erythemic, raised annular plaques, and then they crust.
Interesting. All right. Thank you so much, Alex. And if anybody's got any questions for Alex, if you email at hello@vetsnorth.com.au, I'm very happy to pass on those questions to Alex, and we will get Alex's details and things up on our website in the next couple of weeks, and you will all be able to ask her more questions more directly through a consultation. I'm going to hand over to Paul. Paul is an ophthalmology resident. I'm going to say nearly finished because I'm an optimist. And is going to run through some of the ophthalmic manifestations of systemic disease. And eyes are a very small structure, so I don't think there's much to talk about.
Hold on, I'll just hit share screen.
Let me know if you have any tech difficulties because I don't really know. Oh, well done.
Did that work?
Yeah.
Cool. Okay. So how do I have to go to presentation, view that. Sorry, 1 second. It's a slideshow. Okay, cool. So I put this photo in not because I think anyone's ever going to see anything like this, but just because it sort of occurred to me that this is like a classic ophtho boards exam photo. And it's so cool, it almost doesn't look real. And I just thought I wanted to show it to everyone because I thought that if you weren't doing a ophtho resident, you might never get to see it because it's like one of those photos that's sort of hidden away and always comes up on boards. Does anyone want to hazard a sort of a guess at what's going on here?
Looks like there's massive engorgement in the vessels. Is it intracranial, high intracranial pressure?
No, so it's a really good point. So the vessels are massively engorged. This is actually, it's not even a dog. I should just clarify. I should let you guys know. This is actually a cow's fundus. And you can tell based on the kidney bean sort of shaped optic disc, which is here. And then this is a little tuft here that is a remnant of a fetal part of the nerve called Bergmeisser's papilla. But then these are all just huge retinal vessels and they're tortuous. And they're tortuous because of a systemic disease. So this is actually just probably one of the coolest photos I think I've ever seen. and this is hyperviscosity syndrome in a cow. So this cow had polycythemia vera, and I don't know how it got polycythemia vera or why an ophthalmologist was fortunate enough to get to take the photo. But I guess I just wanted to share this one to show you sort of the profound effect that the body can have on the retina. And it makes sense because the eye is the most important part of the body. So, all right, now we'll move to stuff that's a bit more sort of clinically relevant.
Awesome.
So this is a cat here that I saw about, I think it was about a month ago. Me and my colleague Ben saw it. And I guess we'll start, because this is what I first saw was on the left-hand part of my screen. Does anyone want to sort of just jump in and describe sort of what they see, and I guess what sort of plan or what they would do about a case like this?
Refer.
Yeah, fair enough. But let's say they say no to referral.
Like localized swelling of the conjunctiva. I guess if I would look in an ophtho atlas and then potentially, I guess you could biopsy it. I don't know if that's a good idea.
Great. No, I think biopsy is a great idea, and that's exactly what we did. And the reason that I wanted to show this image in particular in this cat is to sort of illustrate a point that in dogs, eyelid masses tend to be more benign, or usually benign. And if they're malignant, they don't tend to spread anywhere as a general rule. So you get away with a lot more with dog eyelid masses. With cats, when I see an eyelid mass, I worry a lot more. And this one in particular there's a bit of a giveaway here when I look at it, when I look at the photo on the right, when I roll up the eyelid, and that is that the mass is actually primarily sort of, all the irregularities are in the conjunctiva as opposed to the actual eyelid margin itself. And that worries me a bit even more for either some sort of inflammatory process or a neoplastic process. So we did biopsy this, and unfortunately it came back as a high-grade lymphoma. And this was a unilateral presentation, and the cat otherwise completely systemically normal. So we sent it for staging with an oncologist, and at that point I sort of lost contact with the case. But effectively, unfortunately, the decision the owners had to make is whether they exenterate the eye, which is, it's sad because the eye is still visual, or go for something like radiation, which I don't know much about. All I know is that radiation will kill the eye anyway as well. So, I just wanted to illustrate this one because I'll share this case because I thought it was a pretty unique case, but it also highlighted to me like a really important point about cat eyelid masses. Usually when I see eyelid masses in cats, I'm worried about a couple of things. If they're like a white furred cat that spends a lot of time in the sun, I get worried about squamous cell carcinoma as sort of the big one. And if they're, confined to the conjunctiva like this, I worry about a couple of different presentations. There's one which is a lot more benign. It's usually bilateral though. And basically they get accumulations of fat all along. It looks kind of like this, but less pronounced. I'd say that this case probably looked similar to what I'm talking about in its early, like in its infancy, but this is when it's, presented a lot later. And then inflammatory lesions, if they've had an insect bite or something around there. So, you could always give these the benefit of the doubt and try them on a course of anti-inflammatories like orally. For the concern for lymphoma, I use, non-steroidals because I'm scared about using prednisolone. So I just thought that was an interesting case. Any questions on that?
What age was that cat?
He was 8.
Okay.
So yeah, but a good question. Yeah, he was 8. He's a really nice cat as well. So you always know that. And the owner actually came in for and she was really sort of, we had to push her for a biopsy. She was just like, no, I just removed the mass. Like that's what sort of I was told would happen. And yeah, luckily we managed to convince her to do the biopsy, because obviously if we'd removed the mass, we just wouldn't have, we wouldn't have really fixed the problem. We would have done a huge surgical correction, and then found out later that this cat, needed to have its eye removed, or worse, if it had already metastasized. All right. So this is something that you'll probably, see a lot more commonly. Again, we'll start with the left-hand photo. I hope it's on everyone's left. It's on my left. So this photo over here. Does anyone want to describe sort of, what they're seeing? I'll give you the history. This is a 12-year-old, I think it was a cattle dog, that presented for a red eye.
Looks like there's a lot of blood.
Yeah. Yeah, it is a high femur, and that's about all. Yeah, a lot.
Yeah.
Anything else?
Little bit of potentially petechiae. The little
good.
red spot.
Yeah, I agree. There's some little petechiations, and that's important for this case. And when you actually look over onto, the other eye as well, you can see this tiny area of erythema here, just to prove that I do look at the skin sometimes. And you can actually see this third eyelid here, there's a tiny little area of petechiation there. And then when you go in, you kind of have to just trust me here. But if you just see this little spot here on the iris leaflet there that I'm circling, and here, those are actually those are two areas of hemorrhage on the eyelid, on the iris. So what would you guys do if this case came to you in terms of a, as a primary case?
Check a clotting profile to start with.
Absolutely. So clotting profiles I got, and then I heard platelets. Yep. Blood pressure. Yep. Great. So I guess, all these things are really good. And I guess from my perspective, because I don't do body medicine anymore, my primary goal whenever I see something like this is I'm doing exactly what you're doing, and I'm trying to say, okay, is this a primary ocular problem, or is, this a systemic issue that's showing up in the eyes? And you can probably guess what it is based on what the title of this talk is. But there's some other giveaways here, and that is, well, does anyone want to tell me what would push you more towards a primary ocular problem versus a systemic issue? For example, if you saw a case of high femur.
Bilateral?
Absolutely. So bilateral would push us towards, this is probably a systemic issue. And then the next thing, which is in this case, is, multiple areas, different tissue structures which have some bleeding. And that's not the best rule when looking at the eye, because, for example, say we had a big trauma to the right eye, then, you could definitely have some bruising around the eye. Does anyone know where in the eye we could bleed from, essentially? There's only really two places.
Retina?
Yeah, retina is one of them. And the retina is part of the overall sort of structure that I'm talking about. But I guess,
Right.
yeah, the uvea. Yeah. So basically, it makes our job as ophthalmologists really easy, because when I see a case like this, if it's a primary ocular condition, all I have to think about is, where in the eye is it bled from? And the big things, I guess, in a dog would be young dog trauma, retinal detachment, and then, some sort of a neoplasia in the eye, like a tumor arising from the, or in an older dog, probably the tumor would be more likely arising from the uvea. And, apart from that, that's, the rest are really going to be systemic issues. So in terms of identifying a systemic origin versus an ophthalmic presentation, I think, what you guys have already mentioned is perfect. I would take the blood pressure, I do coags, I do, your full general blood workup. And then I would, once I've ruled out all of those things, if the clotting profile is normal, if the bloods are normal, then really, it's got to be a bleed from one of these few structures. And if that's the case, then, you know, the way that we would, I guess, how do you think we would investigate an eye like this where we can't really see to the back?
Ultrasound.
Perfect, ultrasound. And so an ultrasound would give me an idea of, you know, whether or not there's a mass in there that potentially it's bleeding from, or if there's a problem, you know, with the retina, so a retinal detachment. But it can be challenging with masses and with retinal detachments. You know, sometimes you get sort of like a humdinger. And travel history has been put in there. Absolutely, it's important. So I'm guessing you're probably talking from Northern Australia. Are you thinking about Ehrlichia or something like that? Ehrlichia canis? Yeah, I've never seen a case. Yeah, absolutely, it's important to know. So I'll keep going with this particular case. So
sorry, on that, can I ask a quick question?
Yep, sure.
With the photo that you showed, is the on the eye on the previous slide? Is the eye on the left more in the anterior chamber and the other one behind the lens, or is it just that I haven't got the orthogonal shot to see
it's
the
just
right eye
it's
looks like?
Yeah, no, it's a good point. So in this eye, I couldn't, like, you know, this is high femur. This is all in the anterior chamber that I can see, but there probably is bleeding in the back of the eye. We just can't see it, you know, because it's all obstructed. Whereas in the on the eye on my right-hand side, the bleeds that I can see are just in the anterior chamber. I think you just got to be careful with, you know, this dog, it doesn't have it's color dilute. It doesn't have a normal to pedal reflection. So instead you get the red reflex, which is the human equivalent. So it looks like there's bleeding back there, but in fact there's not. There's
red, like red eye, you know, Australian much, red cattle dog. Okay, gotcha.
Yeah, exactly. Yeah. But great question. Okay, so I just wanted to use this next photo here, which is to show you that tiny little bleed. And a bit more of a close-up of these little bleeds. And this really worried me, and it worried me because I knew that it probably wasn't an ocular problem. So I listened to this dog's heart rate, which was the other thing I guess we probably should have spoken about, and it had a heart rate of about 180. So I checked the reference ranges for heart rates in dogs because I wasn't quite sure. And I did find that is abnormal. So I was worried about, you know, generalized bleeding and sent it to the emergency center that was open next door. Unfortunately, Kerry, the criticalist, was able to take the case pretty much immediately. And this was the other thing that I checked. I looked at its gums. And so this was sort of a dead giveaway of the case that I didn't want to see presenting to an ophthalmologist. And luckily they were able to take it straight away. And they worked this dog up and unfortunately they diagnosed it with Evans syndrome. So it had lymphoma and then had developed a coagulopathy. I think that's how it works. Is that right? Evans syndrome?
Evans is a combination of hemolytic anemia and thrombocytopenia.
Ah, there we go.
It might be secondary to lymphoma, but that would be weird.
Okay. There you go. Yes. So they were treating it. Is there a reason that you'd treat it with? I think they were giving it vincristine. Is that
increases platelet count?
Oh, cool. All right, there you go. Well, there you go. Sadly, this dog didn't make it. But I just thought, it's a really good case of what you can expect to see, and I guess what I look for from an ocular perspective. In terms of, if there are I'll keep moving because I probably don't have a lot of time.
Actually, Paul, I'm going to have to hand over to Josh.
No.
Just so that he can run through neurologic manifestations of systemic disease in 15 minutes.
Oh, sorry.
It's so fine. That was really good. I want to see all the rest of the slides.
Yeah, there's so many cool things in derm and
yeah, I feel like we should have maybe done like a full hour on each of these topics, maybe.
I totally was thinking that as well. Like, there's no way, like, everything affects the brain, doesn't it?
Everything. Yes. I was looking at the list of neuro ones and going, whoa, how are we going to prioritize?
Yeah. In hindsight, I wish that over my career so far, I took more videos of my cases I've seen, because I haven't really done that at all.
and filed them as well.
Yeah, so
Like
today
in my phone
I start.
somewhere.
So I don't know how we tackle this, but because yeah, I'm used to being the student with you guys, right? So I was kind of thinking we could just kind of discuss the more common things that we see, and maybe like let's kick off with what are the broader categories of maybe CNS manifestations of systemic disease, so things that affect the brain and the spinal cord.
By broad categories, do you mean like
so for example, like a big broad category would be metabolic changes.
right?
Or,
Yeah.
Well, let's put it this way, actually. Like the broad categories I kind of think of are one being metabolic diseases, another one being kind of endocrine diseases, another one being kind of anything that causes hypoxic injury, which is really kind of only a few things, and then things like neoplasia as well.
Is inflammatory its own, or like part of all of those?
Kind of, I feel like that kind of falls under like the hypoxia kind of category, which is very vague and broad. I don't know how else everyone else thinks of it, but that kind of category, like what I think of is anything causing kind of thromboembolic disease or things that can cause ischemic injury to the brain.
I reckon we could have a subcategory of inflammatory for things like meningitis, like SRMA, for example, which is a systemic vasculitis, which is causing pain, not necessarily neurologic signs, but neurologic pain, maybe.
Yeah, that's fair enough.
And then infectious would probably be on others, wouldn't it?
Yeah, I suppose so. But yeah, but then again, like I guess infection anywhere can spread to the CNS, can't it? So.
Oh, so yeah, you're thinking more like systemic manifestations.
Yeah, not just like primary like CNS infection.
Yeah, gotcha. Yeah,
systemic diseases that then affect the CNS.
What about toxicities? Should put them in there somewhere as well. Are they metabolic? Not really. Could be.
Could be.
Yeah.
They're not being metabolized.
Yeah, well, I mean, that's a good one, isn't it? Like if we're looking at our metabolic issues. So probably like, I think, let's talk about some cool ones, like some fun ones, I think. Like, so I don't know about you guys, but one of the biggest ones I think of when I think of systemic manifestations of CNS disease, I think of hepatic encephalopathy. So, yeah, so I guess what do they look like generally?
Blind?
Yeah.
You might have a temporal association with a meal.
Yeah. We often see them head pressing and altered mentation.
Yeah, looking kind of drunk sometimes as well.
Ataxia, yeah.
Can present with seizures as well.
Mm-hmm.
And cats I found can present with a lot of drooling as well, which I didn't only just recently learned. I do have a video of a hepatic encephalopathy dog, but I don't know if I can show it and if we have time, but
do it.
It's can I share? Oh, I can share.
Yeah.
Is that working?
Yeah, good one.
So this dog, is that working now?
Yeah.
Yeah, so this is the only video I've got. But this dog was referred for an MRI of the brain initially. But it just had these very, very vague signs, no real neurolocalization at all. So it was very challenging to know if it truly was an intracranial cause. But it had it's very subtle, but you can see it's just kind of swaying almost and kind of leaning forward and kind of stumbling forward. This dog was also head pressing. And people were thinking it was blind, but it's, as far as I could tell, it was visual. I'm sure Paul has some more saw some better ways to determine that, but we just menaced it and whatnot.
Did it have a menace?
It did.
Yeah.
But everything just seemed very sluggish. Like, look at this back leg, it's just kind of sliding out, and anyway.
He's going to get stuck in that corner.
Yeah, and he was getting stuck under chairs and stuff. And
yeah.
Anyway, so this was an example of hepatic encephalopathy. He had a biliary carcinoma, sadly.
Oh, wow.
But his ammonia was through the roof.
Mm-hmm.
Do you reckon you would, to get signs of hepatic encephalopathy, you would always have biochemical signs of liver function? Like, could it ever be quiet on biochemistry, like normal cholesterol and urea protein? Will you always get some flags?
Like hepatic synthetic function markers on biochemistry. Yeah, I guess you could see that. So biochemistry, we would be looking for evidence of hepatic failure or dysfunction. I don't think this one had much apart from an ALT elevation.
It's quite shocking actually how, particularly because one of the most common presentations for causes of hepatic encephalopathy is a portosystemic shunt. You can have a completely normally functioning half of the liver, and then the shunt has only bypassed the other half of the liver. So you can get completely normal blood tests with no elevations or changes and still have a lot of ammonia going into circulation and other changes associated with HE. It's quite shocking sometimes to sort of ultrasound a liver and go, whoa, how is this normal?
Yeah. So I feel like going into why this happens in dogs is a whole different chat.
There is a hepatic encephalopathy chapter, so you'll stay tuned and we'll cover it then, I reckon.
But we know it's kind of multifactorial, but ammonia is a big part of it.
Mm-hmm.
You said it had a very high ammonia. What's your opinion of testing ammonia versus bile acids?
So we tested both. So this one is just as part of the kind of regular. Sorry if there's a leaf blower outside my house. So so we tested ammonia just as a part of our kind of general profile, because I'm pretty sure on this one, Bron, the biochemistry was pretty boring and had elevated ALT, and that was really it, I think. So, but the ammonia came back as, I think, 80 or so. And I'm not sure about your experience, but in my experience, most of these kind of come back as quite like 0 or 2 generally, when you're kind of at least querying that. So we did a bile acid stim, and that came back as very hard too. So
the reason for the question is ammonia is quite volatile, and unless you can test it in-house. So I was looking for a comparison between that and bile acids as far as sensitivity and specificity is concerned.
Yeah. So I think ammonia, if it's a normal result, you can't really rely on that as ruling out hepatic encephalopathy. So it is just so many things that can cause it as part of a disease process. So you kind of have to do your bile acid stim if it's normal, is my understanding. Or in both scenarios, I would do it.
And what about like lactulose therapeutic trial before MRI? I mean, I'm just kind of thinking whether or not I have to have more on my radar with the ones that are like silent from a reactive hepatopathy perspective, like with minor ALT but raging ammonia.
Yeah, do you mean like whether you just trial it and see what the ammonia does?
See what happens with the signs like before going to MRI, but I'm just thinking more in general practice.
Fair enough. I mean, this dog never went to MRI because we had our answer. But
yes.
But I mean, if you have a good understanding that it's hepatic encephalopathy on bile acids and ammonia, then probably that's as far as you need to go.
So, like pretty much all dogs with hepatic encephalopathy will have elevated bile acids.
So
bile acids quite sensitive for shunting. So I think where most emergency centres will have the capacity to do ammonia, because it's those emergency presentations where you need to know right now, is it hepatic encephalopathy or is it a brain potato that it's not worth going ahead with treatment. So ammonia is kind of really emergency presentation, emergency setting, whereas bile acids is probably a better test, and that's what I'd say to do in GP, because you're not going to be seeing those really, really unwell ones usually.
Yeah, totally. Yeah, so okay. Another one. So when looking at, well, what's another metabolic, big broad metabolic one? Very briefly. Well, the one I think of,
Hypoglycemia can have many causes.
hypoglycemic. Yeah, definitely. It can vary from like weakness to through to like seizures. And there's, I guess, many causes of hypoglycemia as well. Which has seen definitely the trend of this chapter.
But what are they?
They're the ones that like you, I'm not sure how much experience you've had with those, but the ones when we have them in hospital, if they are seizuring from their hypoglycemia, like you just have to give them obviously glucose to treat that issue rather than anticonvulsants, generally. So they're always quite different.
The seizuring is almost in some sense an end stage. There's other signs first. And there's many systemic diseases and behavior activity diseases that can cause it.
By the time dogs are seizuring from their hypoglycemia, in hindsight, owners report 3 months of altered behavior, but that altered behavior is so subtle that they often don't present until the seizure happens. But there's definitely changes quite long term, like you say, Jeff, before they become really overtly neuro, but it's just very vague before that. What about hyponatremia, hypernatremia?
Good one.
It's a big one. You've got 2 minutes.
Yeah, so dehydrating the brain, swelling the brain, those kind of things occur. So again, lots of causes for both of those things, and often it's associated with free water. It's probably kind of key there. Typically, again, we're seeing things like cerebral edema when the cells become dehydrated, and like particularly in like hypernatremia, so the fluid's getting sucked out of the brain. You can see things like microhemorrhage as well, I think. So again, very broad. I think it's just more generalized brain signs that we're seeing. So yeah.
And I think most of these presentations are going to be quite vague. Like we're going to have altered behavior, head pressing, ataxia, very generalized. I think systemic manifestation, the neuro manifestations of systemic disease are just going to be very whole brain or whole nervous system affected. So they're all going to be quite similar presentations, and that's you have a neuro presentation, you do your blood test, there's no electrolyte derangements, there's no ammonia elevation if it's an emergency, no bile acid elevation if it's not an emergency, and then you say it's probably not systemic disease, it's probably intracranial disease, right?
Super important, isn't it? Like I guess that's probably the main take home, isn't it? Like every kind of neurological case, it's why we break everything down into intracranial, extracranial.
Yeah.
So you have to do your due diligence, because sometimes you will catch these things.
Yeah. And even when you do your due diligence, like I had one dog present, 13-year-old Mastiff or something, like already very much at the end of its life expectancy, presented with neuroscience, and had gotten into the grandma's hash cookies. Bloods were normal. I was like, this dog's got a potato. And then, it started looking a bit more like a toxicity. Never assume.
Hyponatremia is caused by, is that it's increased intracranial pressure? Is that the?
It's what can happen.
Is that what happens? Oh yeah, because I have seen papilledema in cases which then went for a workup, and I think it ended up having electrolyte abnormalities. But I don't know if you could use that to differentiate. I don't know if with intracranial disease.
Could you explain the mechanism of hyponatremia causing edema, Josh? Just to put you on the spot.
Yeah.
Sorry, Josh.
No, that's all right. You get to know what papilledema is. I don't even know what that is. Yeah, I mean, if it's hyponatremia, so you get this kind of osmotic kind of like imbalance. So water obviously wants to go where the sodium is. So the intracellular fluid is going to be quite, I guess, hypertonic relative to the extracellular fluid. So when they're hyponatremic, that free water in the blood is going to want to shift into cells, and particularly into the kind of brain cells, causing them to swell. And as we know, in the brain, there's not much space there. So any kind of swelling is going to cause cerebral edema. So
is there also a demyelination, like is it the central pontine demyelination? Because I remember I had like an iatrogenic cause where someone in a specialist hospital I was working in London didn't quite correct sodium correctly and had a PAGA from memory that got that condition that it was like too fast with correction of sodium.
It I don't know what the mechanism is for like the demyelination. I think demyelination is typically a pretty chronic change, but the actual neuronal swelling and the increase in cranial pressure and then the altered blood flow and sort of impacts of that is typically what generates clinical signs. And if you correct it, this is a bigger topic. I'm not going to go there. We do actually have to wrap up. This has been really fun, and I'd just like to really thank Alex, Paul, Josh for co-hosting this one. It's been really nice for me to sit back and actually God, do I know the answer to this question? If anybody wants to do any more of these, because I think everybody had a little bit more gear that they could present, just send us through an email and we can alter the tutorial schedule and cover a bit more detail. I really appreciate everybody coming and all your efforts. Thanks, guys.
Yeah, thanks, guys.
Thank you, guys.
Thanks everyone.
Thanks, guys. See ya.
Thanks.
Yeah, thanks all.